Hi, everyone, and thank you for joining us again in day 2 of TIO USA. I know it's been an exciting day so far, with lots of discussion around indications, around novel techniques, around calcified lesions. But right now we get to one of my favorite areas, and the areas I've been very interested in for a long time, which is drug-coated balloons. This has been really an interesting journey for me because I've been involved in drug-coated balloons for, I think, over 12 years, along with Bernardo, who you'll meet in a moment. And there were moments where we didn't think, we believed in it, but we weren't sure this technology would become mainstream because we fought a lot of obstacles to get it to where it is. But now it's come to the United States as well. We have one approved device, and a whole lot of different clinical studies that are happening to try and get more devices approved and more indications. So it's really appropriate that we do this session on DCBs and really try and look at the evidence, uh, what drug DCB technique means, and because it's very different to putting stents in, and then use some cases to really show you how we apply the theory and the discussion into real world cases. I'm lucky today to be joined by a really incredible panel of experts in the field. So my good friend, co-director RJ is with us. We have Kate as well, Bernardo. I'm not sure Rob's going to join us later or not, but between the four of us, I'm sure we're going to keep this interesting. We look forward to hearing and discussing your questions. So please use the chat and send us any questions you may have related to the presentations, and we'll try and address them. RJ, we're going to start with you. Let's set the scene for where we stand with evidence and really the guidelines and where DCBs are going to fit into the US practice.
Oh, thanks so much. And I took some liberties with this talk, and I'm going to be talking a little bit about cases, and I'll weave in the evidence there as well, just sort of set the stage for where we could potentially be using DCBs in the US, because we've only had them, as you said, Azim, not too long. And a lot of us are trying to play catch up with the way that we've seen people from Europe, folks like yourself, Bernardo, and otherwise use DCBs. And so from that standpoint, we'll start with just talking about alternatives to stents, because in the US, it's been all stents. And the reason for stents wasn't for restenosis or anything like that. It was to prevent this from happening. When you did a balloon angioplasty, you'd get this angry hematoma, risk of abrupt closure, and stents scaffolded it open very, very nicely. But the problem is that stents are not immune from side effects. And obviously stents can thrombose, and we can reduce the risks of that. But beyond that, and one of our colleagues published this in JACC, even when you do this, the procedure well, there's an accrual of rates of events, about 1% to 2% per year, that happens beyond the stenting period. And so it's not that I used to tell patients, if you don't have a restenosis event in the first year, you're going to be fine. That's not true. You continue to have events over time. And so beyond that, let's talk about technique and the ways that stents can fail. So this is just an example of a case. Patient presented with a non-STEMI, so yes, restenosis is not benign, and diffuse ISR of this proximal RCA. And the question is, why did that happen? Well, one of the reasons is if you look at the imaging here, these were 2.5 stents placed in the prox RCA. The vessel is massive. It's 3.5, it's 4.0. And so that's why these restenose. And there's this historical loss of knowledge that occurs when, studies are not coming out during the time of your training. And so for our fellows, we try to emphasize this concept of bigger is better. Still applies in the DES era. It still applies in the DCB era. And the idea is that if you get a large lumen at the time of your initial PCI, even if you have some restenosis or neointima or neoatherosclerosis, you're going to accommodate that better because the lumen that you start with is so much bigger. And so this concept, bigger is better, is still one that still applies. Well, what about other ways stents fail? More potentially commonly than under expansion is just this conventional neointimal hyperplasia. And so this is a case that we did with IVL as part of the shortcut trial. Got a great result with DES, top class DES imaging guided. And 10 months later, the patient presented with this focal restenosis in this proximal RCA. You need to figure out why this happened. And so we imaged it. And what we ended up finding is this is what you see on IVUS, which is classic neointimal hyperplasia, where the stent itself is expanded very well, but there's neointima within the stent itself. And so that's what it looks like on IVUS. And the question is how do we treat this? Well, thankfully, after Agent IDE, we can treat this with stents. We can treat this with DCBs. We probably wouldn't treat this with a conventional balloon alone, but there are a variety of ways of doing this. And there are some arguments to be made for less metal in these circumstances. So this is what it looks like via OCT, where you see clearly this tissue inside the stent. And what we ended up doing in this case is it was focal, and I elected to treat it with a DCB rather than a DES. And we'll talk about some of the comparative data in that regard. The idea behind this was to reduce metal and also to run the risk of lifetime management, where we know these patients often come back with recurrent events. And this is the final angiogram after I used good prep, imaging guided, and then a DCB to treat the ISR. And why did I treat it this way? Well, clearly, we know that this is better than a conventional balloon. And Agent IDE, Bobby Ye presented this data recently. 3-year data shows a continued reduction of events with a DCB, the agent balloon, compared with a conventional balloon alone. And it's not just the first event. These patients often come back with recurrent events, and those recurrent events are also mitigated by the use of a DCB up front. Some people would argue you should treat this with a stent. And the basis upon this argument may be from data such as Solution ISR. If you'll recall, this was presented at TCT, published secondarily in JACC, and the overall performance of the Solution DCB was very similar to the standard of care. But the standard of care was a mixed blended group of some balloon angioplasty and some DES. And when the data was split out that way, there's actually a clear benefit over balloon angioplasty alone, but perhaps a decreased efficacy relative to a second DES. And some have said, well, this is the reason you should just put a drug-eluting stent in. The problem with that argument, though, is that there is a problem with recurrent layers of metal. And especially when you look at recurrent events like lifetime-related events, we start seeing that if you look at data out to 10 years, this stent-based approach for the treatment of ISR perhaps becomes a little bit disadvantaged. And it may be because the stents themselves elicit this restenotic response. This is an intriguing concept. We still have to follow this for longer. But what you sometimes see also is that it's not just one event that happens. Many of these patients have recurrent events, 4, 5, 6, 7, even 8 events in that 10-year period. And so by starting with not another layer of metal with the DCB, you may actually be able to still preserve the option to use a stent later. We just don't know which of those things is any better. So the clinical need for DCB, though, extends beyond ISR. We know clearly we want to avoid multi-layer restenosis. We want to avoid treating additional layers of metal, but we may also be able to avoid permanent implants and shortened DAP durations and things like that. So ways to improve late DS outcomes, maybe don't put a stent in at all. And so I'll show you some examples of this. I'd be remiss if I didn't share and say where I got this from. This is from a zine. This is a lesion that many in the US would not even treat because you don't want to be ballooning something like this. But intriguingly, if we treat it with like a DCB as he did, you actually see with late follow-up, the vessel grows over time. So not only do you avoid putting in a stent, but you restore vessels to states where they were previously and you wouldn't even know that. The reason this can occur is this phenomenon of late lumen enlargement. This may be something that's drug specific. We don't know the answer to that. And we don't really fully understand. Is this just expansion of the vessel? Is it better flow? Is it actually positive remodeling? All of these things are really, really intriguing and we need to learn more about it. That having been said, this affords us a lot of opportunities to treat patients. So this is a case that technically in-stent restenosis, but not really, because this was a great result left main to the LAD. And as is wont to happen in these circumstances, patient comes back with ostial circ restenosis. Rather than putting in another layer of metal, what I ended up doing is imaging it and actually ballooned it very well first to prep, and that's something we'll talk about in the discussion, and then finishing it with a DCB. Why did I do that? Well, I avoided putting more layers of stent at the carina. If the patient recurs, we can obviously stent it at some point later, but this way, at least I preserve the architecture of the vessel and get a good result, as you can see here on the right of the slide. I'll go back. Let me go back one more, and then you'll see what it looks like afterwards. So why do I think this is a reasonable approach? Well, I think there's some data out there that shows, some people interpret REC cage-free 1 as a trial, randomized trial showing that DES are clearly more efficacious than DCB. That may be true in all vessels, but to me, one of the best analysis from this trial looked at the analysis by vessel size. If you have a very large vessel, you're going to have less side effects of having additional metal there. But as the vessels are smaller, this is where DCBs may tend to shine. And this is an argument that we've used to sort of conduct and devise several trials that are ongoing now in the United States, looking at the use of DCB in other target areas. Here's another example of a case that I put in a randomized trial not too long ago, mid-LAD lesion. If you notice where this is right around a site that would potentially be anastomosis for a lima if the patient were to restenose. So why not treat with a DCB? In this case, it required a lot of prep, scoring balloon to NC balloon, going back and forth with IVUS and making sure it's okay. But after all that was done with a DCB inflation, this is the final angiogram that was done. Why did I do this? Because I thought it was good for the patient, but within the context of a trial, hopefully we avoid putting metal in there, preserve distal options for the patient, and obviously the patient can get stented at some later date. One other case I'll show you, LAD diagonal disease. This is an elderly patient. We can appreciate the diag has a lot of disease in it. There's another subdiag as well. And this standard fashion in the US would be treated with a two-stent strategy. But the problem with a two-stent strategy is as I get older, these are all the steps to a DK crush. Do I really want to go through all those steps, or is there some other way of doing the case? In this case, I thought there would be. And so I dilated the diag. I treated it as a vessel that needed to be treated in its own right. There's a dissection there that shows that we've done a good prep of that vessel, and then ultimately elected to use a DCB on the side branch and then basically stent the main branch. So here's the result after DCB, stented the LAD proximally. And the reason I did this, and I remember getting into an argument with our fellow who said, oh, you got to stent that. Well, the reason is there's data from folks like Bernardo's that show that many of these non-flow limiting dissections actually heal. And so just watching it in the lab, making sure when I stented the LAD, I still watched that diag, was a very reasonable approach. And this is the result we ended up with. Single stent to the LAD, DCB to the diag, and this patient has done really, really well. So to conclude, hopefully this sets the stage for a good discussion in the further presentations. I do think stents will always have a role. The guidelines are going to say that. People are going to agree that for flow limiting dissections, territories where we can't take the chance of closure, and then things like severe calcium or reentry zones after a CTO, for instance, we're going to need to stent those. But DCB for ISR is a no-brainer, especially considering lifetime management of ISR. And for other indications, small vessels, side branches, even de novo disease, there may be a really, really good option. But we need meticulous lesion preparation. We need high volume experience. We have to understand the imaging and physiology when we do it. But if you do that, it becomes kind of cool to do coronary interventions. And although Azim, as a structuralist, he still is really interested in coronary interventions because it's gotten super interesting again. Thanks so much for listening, and happy to take any questions.
Yeah, I couldn't agree with you more. Even as a structuralist, I like doing coronaries in the current world we live in, where we're just not banging stents in. And because it actually does require some elegance, some finesse, some thinking about what we're doing, because we have all these options. So that was like a really great overall description. Rob, thanks for joining us too. We're really lucky to have you. So we're going to go, before we go on to Kate's presentation, where she's going to take us into a practical how you use DCBs and ISR. There are a couple of questions coming from the audience. So maybe I'll start with Rob, and then I'm going to go to Bernardo. So Rob, there's a lot of questions about if in treating ISR, right? We have now multiple options. We have DCBs, we could put another stent in. I guess in some places there's still brachytherapy, or there's just plain old pulva. How are you thinking about your patients who come with ISR, and whether you're going to give them this new technology or you're just going to stick to what you were doing before?
Yeah, it's a really good question. And I want to start off by saying that anybody who thinks that they know the definitive answer probably is not being super truthful. I think the reality is that we have enough therapies now that POVA alone is probably pretty far down the list. Like that's probably done. For single layer ISR, honestly, I think it probably depends on vessel size. We know that DCB tends to outperform stent, whether it's de novo or in previously stented lesions, as the vessel gets smaller. And there seems to be a cut point somewhere around the 3 to 325 range-ish. So I think in big old stented, previously stented vessels, big proximal vessels where you can get good lesion prep, a second layer of stent is probably not unreasonable, to be honest. But as the vessel size gets down, as the other reasons for the stent failing in the first place, severe calcification, et cetera, that's where DCP is really going to win the day. And I think that there's still going to be a role, and obviously with double layer and beyond, it's clear DCB. Now, I think what we are shifting to is that you probably need to fail a DCB for double layer ISR before you get breaky. Although, Kate's got some really cool experience that I would obviously defer to her with some single layer breaky and some other things. But I think for the general person, it's depending on the size, potentially second layer versus DCB. Then once you fail that, you're still going to probably need there's a brachytherapy until we get everybody doing better vessel prep so that we have lower rates of ISR in general.
Yeah, it's interesting that when DCBs really became commercially available and widely available in Europe, brachytherapy just disappeared. We used to have brachytherapy in Europe, and DCBs completely replaced it, and there is no more brachytherapy available in Europe. Bernardo, you've lived through the entire spectrum of DCBs. We both have from the beginning. When it comes to ISR, one of the confusing things for our colleagues, a lot of us believe, DCBs should be your first approach in ISR, but the European guidelines just downgraded this, right? They said that, it's no longer a class 1 indication. So, I mean, you can't blame, our colleagues, especially the young ones, for being a little confused. Can you give maybe just very shortly some insight in how you interpret those guidelines?
Yeah, this is a very, very hard point. If I have limited time, I will try to be very short. And I have a conflict of interest. You know that just when the study by Bruno Scheller came out, the PACO cut for ISR, I started using DCB for de novo. And then we did Picoleto immediately. So that's the top. So DCB are done for native vessel disease, but I will go through that later. So ISR, currently available stents are working well. If you see Illumin 4 data, for example, the sub-analysis with the, of course, OCT based, ISR, TLF 1 year, 7.5. So it's very tough to reach this TLF at 1 year, At longer follow-up, maybe DCB can catch up the stents after some time also in the ISR, like we have shown for de novo disease. So what I usually suggest is that don't be stuck on DCB or stent at the beginning. So do your imaging base, 100% of the cases, ISR, prepare correctly the lesion. I will show a case about that actually on ISR. So prepare correctly the lesion. And when you are happy, when you have achieved a good lumen, then decide if to go with the DCB or to put another stent. This is what I usually suggest, to be very condensed in 1 minute.
Great. Thanks, Bernardo. Kate, we're going to move on to your presentation. Maybe also when you present, maybe take us through, since you have the availability of multiple ways of treating ISR, what made you choose the DCB in this patient?
Yeah, no, it's a great segue to that. So I think this is a gal where, honestly, the anatomy lends itself to a number of options, but then sometimes the clinical factors or what kind of result we get actually during the case, it's an evolving decision. So I'll be interested to hear what you all think about this case as well. So this is a 74-year-old woman. She has horrible peripheral vascular disease, has had endarterectomies, failed bypass grafts, and is basically coming back to the lab frequently with vascular for POBA of her left lower extremity for rest pain ischemia. So she's had quite a go with that. Previously, she had presented with an end stemming, had RCA PCI done in 2021 and had some LAD disease at that time. So we thought that perhaps that had progressed slightly because her EF is down 25%. But looking at the right image, I'll see if I can get that to play again with this. It's sort of angiographically ambiguous, but looks kind of funny in the ostium, and we were concerned that that's fairly tight. We were getting some dampening with the 6 French. Because of her vascular issues, she's actually had a brachial cut down repair for an issue from a prior intervention with the vascular folks. So this was my last of cases at UW and the first time I did left ulnar access. So we're 6 French left ulnar, just to paint a picture of how perfect everything is. So we were only able to really get a 5 French JL in to take these pictures. So left side is imperfect, but I believe that there probably is something going on just based on her EF presentation. But we thought that the right looked a little bit more suspicious. So I think first thing was, let's just try to figure out what's going on there. So this time of the year, we're letting the fellows drive a lot of that. We said, well, it's going to be challenging enough to engage. I would maybe just go right to IVUS because we have some suspicion that there's something going on there. And predictably that wouldn't go very far, but we got it right to the ostium. You can see that similar to the imaging they got with the volcano IVUS at the time of intervention several years ago. It's like a 3.5 to 4.0 vessel is what they had seen then. They didn't quite deliver distally the time at the prior intervention. And we're having similar issues, I think, with just her access and, she's come in a difficult situation with active limb ischemia at the time. So I think they kind of said, let's get this done. And then we'll check on it when we do the left-sided disease. But because of her vascular issues, PAD being so active, she actually never came back in between. So taking a look at it, we figure, first steps, if I know I'm coming in for ISR, I typically just take a NC balloon that's reasonable size. If we have data from the prior intervention, then that's quite helpful. And sometimes there is really pretty easy to manipulate neointimal hyperplasia. I've had 1 or 2 patients who are just a factory for NIH, and you can balloon it and it almost immediately looks good on imaging. But that's really a subset. I think most of the time we're seeing some issue with the stent, something else that's going on that is more difficult. And so honestly, I feel like that just gives us a little bit of a test of once we've ballooned, we can see. So we're having a lot of issues with guide engagement. So honestly, partially a 3.0 balloon, which semi-compliant is just enough to reseat the guide and then try to get our IVUS in for this first picture. So kind of next up, we're just trying to figure out what's going on. And I think, to Rob's point, every time people say they know exactly what's going on with ISR or the right answer, I think we're reaching a little bit, because even in the studies, there's such a heterogeneous group that are compiled into ISR. So there's clearly people with stent problems. There's clearly people with neoathero. There's clearly people who just have a biologic activity for neointimal hyperplasia. So let's see, sorry, we get this to go forward. So in her case, the first IVUS run shows this is a kind of still frame of our minimal area at the ostium. And as you see the IVUS play, the stent is sort of reasonable here. There's a couple of funny spots, might be slightly underexpanded. And then right near the ostium there, we're getting kind of a lunar eclipse type effect. And so whenever I see that, I figure it's either stent deformation or typically a calcific nodule. I think given the timeline and her substrate with some CKD, that makes the most sense. She was in an episode of AKI after they had attempted some diuresis. Her creatinine was actually getting a little bit better after diuresis, and she was feeling her chest pain was better. So, but we're also thinking about contrast limitations in this case just because of that. But putting all that together, we figured there's going to be some calcium modification we need to do. She's fairly well compensated, but even after diuretics, her LVDP is like in the 20s. This is kind of a new heart failure presentation. So I think we still have to think about ischemic burden for the case. And so sometimes that will make me skip a step. I think you can always try things and re-image and see how it's going. But, every time we put a guide extension down, we tend to leave it there. We're causing some ischemic time. We're 6 French because of our access limitations, and because of her PAD, it's actually really hard to assess her blood pressure non-invasively. So I'm just sort of mindful as we're working here about all of those factors. So I figure, the way seemed like the best way to kind of cut to the chase to see what we could get here. We took a 3.5 NC to real high pressure to get our 6 French guide extension down, and then took a 3.5 shockwave IVL balloon. In part, I think a 4 would have been reasonable, but I was just more confident from a guide extension compatibility that we'd be able to get that there. And it looks tight enough that we should have good contacts. I'm hoping that will still give us basically a similar effect. And so, the NC balloon on that first corner looks pretty good. IVL is looking reasonable. We ended up having, we still see a little bit of a waste with the IVL balloon, which is not unusual at the low pressure that we're at. And so again, we just sort of skip ahead and actually come back with a cutting balloon because we know that these areas are pretty nasty. And so I don't know what modality is best when you have a nodule that's crimping on the stent, but I feel like multiple modalities typically helps. And this is a gal where I'd probably rather avoid atherectomy if I can, just because of her clinical presentation, at least at this stage. And so overall, we're still just sort of focused on the vessel prep and debating about what our final exit strategy is going to be. But a 4.0 balloon with a lung inflation looks pretty decent there. And then we see our final IVUS run here on the right, following up all those therapies. So we've done several things. We've sort of checked in on the vessel, and it's far from perfect, but we'll see in the Next slide. So that's our MSA now here at the osteum. So it's far from perfect, but we're getting into the mid 7 range. And so I think this is where, to your point, like there are a lot of options, and we're often thinking about what's going to best fit this patient profile, what I think is less likely, what's going to serve them best in the longer term. There are patients who are back so frequently, and we sort of see this acceleration where they keep getting stented and it snowballs into the fact that they're back like every 3 months because they're having recurrent ISR issues. And so those are kind of worst case scenario, I think, where it's hard to keep people out of the lab and you worry about iatrogenic effects of that many procedures, and their options really become more limited. So I think, partially the Reiki experience just sort of showed us some of those outcomes, that especially if you have to keep tacking on a stent to the very distal vessel, or we're getting past that second layer, that it just gets a lot harder to achieve good results for these folks, or we have to take more risks during the procedure also to achieve that. And they're more likely to have a failure rate. I think, in these single layer issues with the calcific nodule, if we've modified things well, you could argue that choosing a stent with a higher radial strength is probably not the best time for our ultra thin strut ones. That's why we carry 2 options on the shelf. And I think that that's a time that is reasonable. But we have certainly seen those fail because, the same issue is there, and we can have that come back. I think partially I'm wondering in these cases is what's the benefit of the scaffolding? If it's really going to help in a case where we fractured the stent because we've had to really hammer it and we had to rota through all this stuff, I'm worried that we've really compromised the underlying structure. I think resenting is usually my go-to in single layer in particular. But I think in other cases where it's like, I don't know that it's going to look, I don't think our MSA is going to be a whole lot better, or that scaffolding is going to change things a lot. Or in this lady, partially, I think I'm worried mostly about what if she needs to stop her DAP. So she's basically committed to anticoagulation. They do not hold her rivaroxaban or DOAC for her vascular procedure. So if she does run into an issue, they're considering a follow-up surgery that had been scheduled for the following week. If they are going to hold anything in the shorter term, that I feel much better about that with DCB after we've done all this work, rather than a stent that is probably still going to be imperfect with a second layer. So I think kind of thinking through all those things, we're like, she's doing okay. We haven't used a lot of contrast. And so we're going to kind of take our win and decided to do DCB. And I think you could argue, any which way. But I think in her case, we are now going to take her back to look at the left side disease next week. And so we can also keep reevaluating those factors. And sometimes I use that staged procedure as a way to just reassess how things are going. Ideally, if it's like a month or 2 later and you're starting to get ISR, or it already looks like that's collapsed, then I think you could choose a different strategy too. So that's kind of my take in a lot of those cases. But thinking about her physiologic milieu and the result we got, we figured, I'm going to try DCB in her. So, kind of one of the common things is that currently we just have the 30s as our longest balloon in the US. A lot of times, when I'm choosing brachytherapy, truthfully, it's because it's just a whole RCA CTO. We had to clean out the whole thing, and we really want good coverage. And I think what we learned from our failure rate in the brachytherapy space is a lot of times it is probably a little geographic miss. It's like those areas where right on the edge of where we treated, some theorize that that's activating something, but probably more likely is our balloon is activating something in that region, or we ballooned a little more distal than we were, covered with the catheter. And so I've really tried to get good margins with that. The fellow's doing this whole case from the practical standpoint. And so it's sort of going through like, okay, I want to make sure that you get the osteum, but we're going to try to cover everything that we did balloon here. And we are just a little short on the corner. And I think, honestly, I didn't know this when we first started our practice, but with the pass-through payment, you can get a second balloon covered. And I figure I don't want to leave. This lady has a million reasons why she could have target lesion failure. I don't want to add to that. So we ended up just doing one more. And I think angiographically a reasonable result. So now we're not getting any gut pressure dampening. So I think overall for me, the main difference that's so wonderful about DCB, despite having brachytherapy before, is like we can do this ad hoc. This was a NSTEMI add-on case. I think we take our win, we sort of stabilize the situation, and we hopefully still leave options open for her. And I think for someone who is not going to get bypass surgery ever, and has other limitations, that we still have a lot of ways that we can take care of this vessel if need be. And on a different day, I'd be willing to do more atherectomy or things if we sort of got the feedback from the vessel that this wasn't enough. But a lot of times that works. And I think, unfortunately, we are all seeing a lot of this, and it's a high rate here in the US of our percentage of interventions, but I think we can't treat it as a one size fits all algorithm. And so a lot of that for me comes down to the imaging, that we really just don't know how good of a result we're getting without repeat imaging a lot of these cases. I think the timing of stenosis often predicts the disease substrate to some degree, but we still have to double check our work and see. So even if you're like, oh, that's obviously calcium, we don't often know how good of a result we're getting from what we're trying until you re-image. And we have seen a lot of cases where that double layer goes in, the MSA is still pretty poor. And then those cases seems like that's the substrate where some of those patients really accelerate and then are having a lot of ISR that's recurrent. I think in these cases, while neointimal hyperplasia isn't the driver of her presentation, overall, when we have to do a lot of work on that, we do see those patients come back at a higher rate. I think the data supports that. So even if we're just doing other vessel prep that might be activating to the vessel, I'm covering that with DCB or brachy when available. But interested to hear how you guys might have approached that differently. Thanks.
That's great, Shane. Okay, thanks for a great case. And I think, you highlighted, I think, something we keep trying to emphasize when we talk about DCBs, which is how important lesion preparation is before even thinking about using the DCB. Because, you can go into a case thinking you want to use the DCB, and you can change your mind later. It's not like you open the DCB the minute you walk in the room and they start to prep it, right? You make that decision later. So there are a couple of questions from the participants. I mean, the first one maybe I'm going to ask you, Kate, which is someone's asking about sort of, I think if I'm interpreting this, it's dwell time. So like, how long is it safe to have the DCB in the artery before you say, okay, you can't use that DCB anymore?
Yeah, it's a great point. So I think part of the question is like, when does the coating expire once we enter the body? I think from the bench testing that we have, you have basically 1 to 2 minutes to try to deliver it. And there is some support for using a guide extension to just minimize disruption and drug loss in the entry. And I think that's also feedback from the whole case. The guide was a total pain this entire case. We're, leaning over the patient for left ulnar access, torquing it managing it is a little bit tricky. So I don't want to take any chances. So in a case like this, I'm just going to pull a guide extension and use that up front. And I think that makes it much more predictable and likely does help with some of that. Then separately, there probably is some drug on the balloon after that first inflation, but we're targeting a minute at least for optimal transfer. And a lot of patients, by this point in the case, they have some ischemic preconditioning just from the work we've been doing even. And so honestly, most patients will tolerate 2 minutes. And if they're doing fine, we're not worried about other factors, then I'll go ahead and do that. I think, talking to the engineers, there probably is some drug left over. And I know folks will sometimes try to like touch up another spot nearby, but I just think we just don't know how predictable that is.
Yeah, I think those are both great points. I think I also use sort of 2 minutes as my dwell time limit. If I'm in the artery in contact with blood for longer than 2 minutes, I accept that I probably need another drug-coated balloon. And, the one thing that we should talk about and mention, and I'm sure Bernardo will mention his presentation, is that there's no class effect from DCBs. They're all very different. And so even when we talk about things like dwell time, how much drug is left, it's very dependent on the platform you're using. Some platforms may have some drug left, others will have nothing left after you've done the first inflation. Ajay, one other quick question from the audience is, I think this is an important one. Someone says, what are the biggest technical mistakes that I could make that lead to poor early DCB outcomes? What should I watch for?
I think that inadequate prep is probably the biggest one. I definitely know that there were people that felt when agent got approved that, oh, I can just go in with the agent and use that as my pre-dil balloon and treat. And that's definitely not the way that you got to think about it. Conceptually, this is the drug delivery device. So you need to do all your work first, and then you're just finishing with the DCB to deliver the drug adequately. And by the way, that should help you with your delivery as well if you prep it very well. I think the only other thing I would say is don't get so complacent that you start, you resist the urge to, if you have a flow limiting dissection, to put in a stent. There are cases where you're going to have to bail out and you're going to have to put in a DES. It's just that the paradigm of DEB first is one where you try to manage it with a DCB, but there's some cases where you're going to have to change what you do. So be flexible in your thinking.
Yeah, absolutely. Rob, very quickly, intravascular imaging and DCBs, particularly for ISR, obligatory, strongly recommended. And there's a lot of discussion on when do you do your final run? Do you do it before the DCB or after the DCB?
Yeah, I mean, I think we've mentioned before that stent failure is so low at this point that when it occurs, there's a problem, and not sorting it out. I just don't understand, I guess, the thought process there. Like, one has to use intravascular imaging because it shouldn't have failed, right? There's a problem and one has to figure that out. And one thing about DCBs, I can tell you, when I started my de novo use of DCB journey 18 months ago or whatever, a lot of my early failures were because I just didn't know how to vessel prep. And I had to go back to the drawing board, ask older colleagues, talk to my European friends, and sort of say, what am I missing here? And it was really the vessel prep part. And so whether you're talking about de novo, ISR, you have to get good vessel prep. And there's going to be cases where you're going to have a lot of recoil no matter what you do. That's not a great DCB case. Now with ISR, it should be less than de novo, but intravascular imaging is mandatory timing wise. I think that an initial run to figure out what the problem is, and then you really probably need a second run after you've done whatever it is to mitigate the problem, to ensure that there's been good plaque reduction, that there's been good stent expansion, the MSA is reasonable, and that you're ready for DCB. After DCB, there's this, maybe you're rubbing drug off, yada, yada, yada. If you've already made sure before your DCB you're good to go, I don't know that there's necessarily a need there, but again, we're continuing to learn from a lot of folks in that regard.
Great. Thanks, Rob. Bernardo, we're going to pass it on to you to take us through some of, what's beyond the current indications.
Yeah, thanks, Azim. Can you see my slides? Okay, I guess
yes,
this is
can.
a yes. So, okay, thanks. All right. So I would say we could stop after this slide. Complex PCI. So I think that you, Azim, and all of the other folks that we usually meet during the conferences, symposium, DCB, we all agree that DCB is particularly fit for a complex PCI. Why? I'm trying to show you this. It's substantially, it's easing the way we are treating complex PCI. And the other thing is that we are not putting metal if we are not able to achieve a good lumen. Or,
to a plug?
Excuse me? Oh, okay. So, so the first thing is that we don't want to put metal if we are not completely sure that we have fixed the lesion in terms of, for example, getting rid of the calcification or of the impairment that the metal would have to expand if we have a high calcification. And then we have data that's quite clear that the more complex the patient and the more complex the lesion, so let's say chip, overall, the worse is the outcome with the currently available drug-eluting stents. And there is also a gap in terms of events as compared between simple and complex PCI in terms of cumulative events of MACE. This is something that is very important. And then the predictors of the failure of currently available drug-eluting stents are associated with two items, which is stent under expansion and excessive stent length. Okay, and these are things that are quite common in our daily life. We can see very often patients coming back for ISR for one of these two lesions. One is that if we have like a 12 lesion, why do we have to put a 25 stent? Because we are increasing, every single millimeter of stent is associated with an increase in target lesion failure. So with all of this said, we have to remember one specific point, that after 1 year, a stent is a stent. So after 1 year, a drug-eluting stent is a bare metal stent. We know that from the pathology, because we know that any drug-eluting stent is not eluting any drug after 1 year, one. And two, we know from the data from several trials, which are showing that the events after the first advantage in terms of a reduction in TLF at 1 year are quite the same between drug-eluting stents, all of them, and bare metal stents. So in this particular scenario, I think that drug-coated balloons do enter. I showed this slide quite well, not because it's one of our publications, but because the fellow that created this one is amazing. He did a great job in showing which are the indications where we can use drug-coated balloons so far, and how are the possibilities where we can expand this expertise. But, and we can discuss about that later, always remember that if we are approaching this technology, we should start with the simple lesions. This is a very important message. So let's start with the diagonal branch. Let's start with the distal LED, and then let's do a follow-up with the patients, also a clinical follow-up. Let's see how they're working. And then we can expand our expertise in more complex lesions. Very luckily, and we all were part of this consensus document. Very luckily, Patrick Serraios did coordinate the first DCB arc, which after 2.5 years came out with two important publications in the European Journal, one, and the other one is in JACC, showing how we should and when we should use drug-coated balloons in our daily practice. And pretty much what Kate and Jay said earlier, we are gathering all of this information here, which means two important things. We should understand when to convert to beta stenting, and two, we should be very keen in preparing the lesion in the best way we can before deciding if to use drug-coated balloons. Going into more details, we have this important study from the Korean group by Dr. Shin, which is showing that this is a propensity matching comparison of two big prospective registries. It's showing that if we spare the metal, we have at 2 years lower MACE in a blended strategy of drug-eluting stents for the proximal segment and drug-coated balloon for the distal part. And this information, despite it's not deriving from a randomized study, is something that, in my opinion, is being applied more and more, especially in the United States. And then the role of a blended strategy, so we don't have to be fixed on full DCB. The role of a blended strategy has many, many important reasons why we should apply that, not only because we are sparing an excessive metal implantation, but also from the biological and the pathophysiological point of view, there are good reasons in order to do that. We also have sirolimus. We don't have to forget about that. And of course, in the US, we are not forgetting about that because the second DCB being approved will be a sirolimus DCB. And also sirolimus, not only paclitaxel, actually has shown a pretty good performance in as compared to drug-eluting stent in the complex lesions. This is a 2-year outcome of a study where we compared with propensity matching on a patient level, and we showed that we had a very similar MACE rate, but maintaining the advantage of drug-coated balloons in terms of lower bleeding risk by reducing DAPT after few months, which is something that we don't do with drug-eluting stents, especially in the complex lesion setting. And then we have the calcified lesions, and I'm very proud to present this mechanistic but important study, which Daniela presented at TCT last year, and it's a cardiac study. And here we wanted to see if a full DCB angioplasty in severely calcified lesions after atherectomy or intravascular lithotripsy was safe and effective. And actually, we showed that this strategy in this cohort of 124 patients, all of them have been analyzed by CC in terms of events and by core lab in terms of angiographies, show that these approach of a full DCB in calcified lesions after hysterectomy or IVL is safe, because we didn't show any MI or any sudden death in the first 12 months. And also the performance, the clinical performance in terms of target lesion revascularization is pretty much good in this complex lesion setting with a 6.5 TLF rate at 1 year. And then I want to show you a case which is not that complex from a technical point of view, but is depicting something that we all said. And so it's overemphasizing what we have all said. This is CTO for ISR, but with an extension of the disease in the proximal part of this RCA. We just pre-dilated the lesion with a semi-compliant balloon in order to make room. We decided to use a laser as a hysterectomy here, and we use a 0.9 catheter, which is our workhorse for the vast majority of the cases, the coronary cases, and we use a 60-60 pulses and of energies, and we did 7 runs. So 7 runs, it's time demanding. So up and down, slowly up and down, slowly up and down, and then we assess what we have done here. We did this OCT, which is showing actually the neoatherosclerosis with the calcifications, which was the cause for the ISR, which, as I said, was protruding more proximally to the stents. And we also showed that the stent actually was pretty well implanted. So we had really neoatherosclerosis as a cause for this ISR and subsequent CTO. But we also showed that we had a distal reference vessel, a big vessel, 3.2, and MLA of 2.5. So merging this information with angiography told us that this was not a good lesion preparation, despite we had used balloons, laser, 7 runs, back and forth. So this is why we decided to go on with the lesion preparation. And so we did 2 additional runs of 80-80 with contrast. So, you know, increasing the potency of this tool. And then this was the angiographic result. And of course, we repeated the echo. I'm going to skip this, but the echo, sorry, the OCT. But the OCT did show a clear improvement in terms of lesion preparation and cracking of the plaques, the calcific plaques inside of this ISR. So we had an MLA after the first runs of 2.4 and an MLA of 5.6 millimeters square, only after laser. More potent laser. Then we started, of course, with a non-compliant balloon, 325, according to the size of the vessels at higher atmospheres. Again, this is time demanding, but you need to do that if you want to use DCB in these cases. And this was the angiographic result. Of course, the periphery is not that brilliant, but at least where we had the lesion, we have obtained a good result. And then we decided to use DCB, full DCB, 3 paclitaxel DCB, the one that is available in the US so far, also in the native vessel part, and the result was pretty good according to the tools that we have now. And then the last part of my presentation, of course, we cannot forget about the usage of DCB in CTO. So this is really the future. There is this meta-analysis published last year. Only small studies have been done, only small randomized studies have been done so far, or registries. But this meta-analysis is showing in 2,000 patients with a 2-year follow-up that a DCB approach is comparable to a drug-eluting stent approach. We needed to have more information, and this is why we presented at Europe PCR a few weeks ago the Piccoletto 10 study. Okay, I don't know why it's coming back. So this is a multi-center experience on usage of drug-coated balloons for CTOs. The reason why we did that is that there is still positive experience. We have some in-hospital experience showing the safety of DCB for CTO. For example, we have the ERCTO registry in Europe, and we have some initial analysis from the Progress CTO by Manos Brilakis. But again, all of these studies do not have a significant follow-up. And so this is why we run the Piccoletto 10. We collected 938 patients of CTO cases, all of them treated with DCB. About 50% of them were treated with DCB only, and 50% with a blended strategy. We know that in case of CTO, it's difficult to go away from some stenting. That is something that we knew. Primary endpoint is TVF at 1 year, and co-primary endpoint was technical success and safety in hospital safety. This is the characteristic of the whole population. You can see that ISR is the only minority. These centers were European and North American, but ISR is 23%, and we have de novo in 76%. JCTO score is not that crazy high, so we are not including very difficult CTO cases, but it's 2.12. Of course, it's higher in the blended strategy as compared to the DCB only. Sorry, let me come back to this. And very important, procedural success was pretty high. So 93% of the cases overall did have a success in this PCI. Crossing strategy. This is a very important information that we have. We are biased here. Anti-wire escalation was used in 67% of the cases. We know that if we achieve extensive dissections, it's difficult to go away from also even long stenting. So this is one of the limitations of this study, that we cannot apply this information in ADR or RDR, extensive RDR cases. In-hospital outcome is pretty favorable for this technology. The perforation rate was around 5%. Pericardiocentesis, need for pericardiocentesis was less than 1%. So no big differences with the current outcome, in-hospital outcome that we have with drug-eluting stent. And overall, TVF of 1 year was 9.5%. And after propensity matching, by comparing the DCB only and the DCB plus drug-eluting stent in the blended arm, we can see here that we had a TLF rate of 7.5, no differences between these two arms. And the predictors of TVF, not surprisingly, are non-IVUS usage, are ACS as an indication for the PCI, and of course JCTO score. The higher the JCTO score, the higher the risk of TVF, also with drug-coated balloons. So we have several limitations for Picoletto 10. I'm not going to through all of the details from that, but of course we have some bias in terms of the selection of the patients. We cannot suggest that the DCB strategy should be the first approach after for any type of CTOs we are facing, but we need to decide only after we have prepared correctly the lesion. In the end, we will need for sure randomized clinical data. And this is the publication of the study. And let me jump to my conclusion. DCB represents an ideal tool to navigate into complex coronary artery disease management. I'm talking about diffuse disease, I'm talking about bifurcations, I'm talking about calcified lesions, and now also CTO. You don't have never to stuck on your decision if to use a DCB or a drug-eluting stent, because after lesion preparation, you take your decision. If you are not sure about that part, just put a short stent. What you have to avoid is to do a full metal jacket after you have done a good job in lesion preparation. From a procedural perspective, DCB may simplify the PCI in complex coronary artery disease by reducing total stent length and also easing bifurcation management and allowing also possibly late lumen enlargement. But the key is always to achieve an optimal lesion preparation. Thank you for your attention.
Thank you, Bernardo. As always, an excellent presentation, and you're really pushing the limits with Picoletto. I remember when you did Picoletto, and now we're talking about Picoletto 10. So I don't know if we're just getting old, or you're just doing a lot of research.
Yeah, both.
But congratulations.
Both things.
So let me ask you this one question. We're going to move ahead because we're running a little late. But there's one interesting question, which is philosophical, I guess. But you're the right person. And one of the audience asked, especially when you show, now we're doing calcified lesions, obviously diffuse disease, CTOs, with DCBs, the question is, are we really entering now into a truly metal-less or metal-free era? Do we have everything we need to be able to say we can now offer metal-free PCI to patients?
I think so. I am pretty confident into that, pending more data. But I want to come back to the description of a couple of studies that we all know. We didn't have the time to describe them. Well, Ajay actually did talk about the solution. But so in these studies, we have seen that the outcome after drug-eluting stent is amazing. It's incredible after 1 year. We will see at longer follow-up, but after 1 year, and in the wreckage field, after 3 years, it was very good. Why? Because applying the best way we are treating, we are preparing the lesions, that we are doing that for DCB, did actually lead to an improvement in the outcome of also of drug-eluting stents. So that said, if we apply the same scrupulosity that we're applying for DCB, we are going to have a great result also with the drug-eluting stent. So we don't have to go away from the fear of putting a short stent if you're not confident in leaving the dissection. That's fine, but we have only to avoid the full metal jacket. So I would say I'm very optimistic, pending more data in these specific settings.
So I actually like the comment of the audience member who sent it. They didn't say metal-free era, they said metal-less era, which I thought was actually very thoughtful. Rob, I can't ignore your body language and the fact that maybe you don't completely agree.
Oh, no, I totally agree. I think that if you took that into a room full of interventionalists in the United States, that would be met with a significant amount of skepticism at this point. Just being super honest, there's currently a Boston Scientific stance study right now, which is bifurcations, long lesions, and small vessels. And what's interesting is we're starting enrollment like next week or something like that. So I looked at the protocol, and this is how I've been operating for almost 2 years, right? Like DCBs for daughter branches for bifurcations, for long lesions trying to stent the inflow, DCB the outflow, and then for smaller vessels, honestly, use DCBs because they're just areas where we know there's higher risk for stent failure. And in the right environment where you have to make sure all the patient care and finances and everything is weighed together, this is just what we've been doing. But I have to tell you, if you took that to a lot of people, they would say we're nowhere close to that being sort of standard of care, particularly in the United States. So I just yes, I'm a believer. That's what I'm doing. But I would tell you that if people came into my lab and saw the way that I treated things, they would probably say, really? So I want us to be there. I'm not quite sure we're there yet.
Yes. No, I agree. I mean, my biggest problem with agent stance is that I'm struggling to enroll patients in the diffuse lesion subset, in the long lesion subset, because having used drug-coated balloons for such a long time, I'm struggling with the fact that if I could use 2 drug-coated balloons that are 30 millimeters long, why would I want to put stents that are that long? And so that's where I've been struggling to enroll in that study because I feel almost, I don't want to see full metal jackets anymore after having actually put so many in my career. But yeah, I think you're right. I think it's going to require a culture change, a philosophy change in the US. But I honestly, as someone who's worked in Europe and now worked in the US, I've been surprised. I thought it would actually be a lot harder, the adoption in the US. And when I go and speak to colleagues and I see what's happening, I've been pleasantly surprised. I think US colleagues are not shying away from the fact that DCBs can offer a different way of treating coronary arteries. It may require a little bit more work, but you know what? That's, maybe that's that whole philosophy of we can't just bang a stent in, and maybe we need to do lesion preparation and we need to image is just going to make all of us better interventional cardiologists.
Yeah, Azim,
so
I
anyway,
fully agree with you. And to be honest, what I've seen in the US, and we have discussed about that at EPIC also, is that more centers, experienced operators are using DCB more and more outside of the ISR, so with an off-label indication. So it's a matter of cultural change, it's a matter of experience, but I'm pretty much sure that in, let's say, 2, 4 years, 5 years, we will go there.
Right. Yeah, absolutely. So let's go to the last presentation. We need to get people out of here. There's a lot happening this evening all around the world, and I feel like I'm holding people back from that. So, so let's go to my presentation. I wanted to take you through a couple of cases of de novo disease, and I chose cases that we kind of did in the last few weeks or last 2 or 3 months to try and just share with you how I'm thinking about DCBs and de novo, with the understanding that I'm now an American physician. I work in the same constraints as most of you, in that I have to think about costs for the cath lab, reimbursement, litigation. I work in New York. I got to think about all of those things that I think weigh heavily on many of your minds when you think of DCBs. But let's show you a couple of cases. So these are my conflicts of interest. So we kind of, years ago published the DCB consensus article about what is a good DCB approach. And the thing you've heard in every presentation today is it's about optimal lesion preparation. DCBs, you can't just bang them in. You really have to prepare the lesion properly. And to do that, it means that for many of us, we have to learn how to do POBA properly. I've sat through a couple of presentations recently where, people who lived in the POBA area were talking about how the interventional community has come sort of almost 360. We went away from POBA. It was this bad thing to stents, drug-eluting stents, scaffolds, and now we've come back to POBA. And when you hear one of them present on all the lessons they learned in those early days of plain old balloon angioplasty, it's the same lessons that apply today, right? So we can go back and learn from our colleagues. I think, certainly for me, I teach my fellows that they need to learn how to do POBA the old-fashioned way, which means preferably non-compliant balloons, trying to go one-to-one with your balloon to artery ratio, use longer balloon, inflate them for longer periods, not just quick up and down, but actually start doing 30, 40, 1-minute inflations, even when you're pre-dilating. It gives you a better sense of what the vessel is going to look like, but it also gives you some ischemic preconditioning. And use longer balloons, do repeated inflation. So that's what I mean by sort of old-fashioned POBA. If the results are not optimal after you do that, have a very low threshold to use specialty balloons, whether it's a scoring balloon or a cutting balloon. I think there's really some data that cutting balloons and scoring balloons may have a increased beneficial effect in these patients. There's been one randomized study only, which didn't really show that for de novo. There's been a randomized study that has shown that for ISR, which RJ mentioned before, the ISA Desire study. But I do think that using scoring or cutting balloons, by the fact that they penetrate your dissection flaps more, I think leads to better dissections, and better dissections lead to better drug delivery and better remodeling. It also leads to, I think, less acute vessel closure. And I think also these specialty balloons can relieve things like intramural hematomas. So think about those. There will be some cases where you need to be more aggressive. And I think you saw that too. You need to use atherectomy, laser, IVL. And also we're trying to understand and trying to develop criteria for functional measurements and intracoronary guidance, not just on what the size of the vessel is and what device you need to prepare, but also maybe in the future, is there an FFR or DFR value or PDPA value that predicts a good result and less acute vessel closure? Are there variables on imaging that may also predict that? I think we're not there yet, but there's a lot of work going on in that area. And then once you've got an acceptable result, what does that mean? There were some questions. For me, that means a angiographic residual stenosis less than 30, a dissection that's not flow limiting, where the contrast staining doesn't remain. And generally, you want an FFR more than 0.8 or DPGA more than 0.9 is what I'm looking for. And if you have that, that's when you use the DCB. So that's how I think about it. So here's some cases. Here's a 68-year-old patient. I did a mitral clip-in, has this lesion in the pretty mid to distal LAD that was still causing exertional angina. And it's an area where I don't like putting stents. I don't like putting stents into distal LADs. So for me, this is an ideal case for DCBs. And also, this is the kind of case where I would suggest, compared to my next case, this is where you will learn how to use DCBs. Please don't start learning how to use DCBs like the second case I'm going to show you, where you have to do extensive lesion modification. Learn how to use it on a simple lesion. Look at small vessel cases. Look at cases that, maybe a side branch of a bifurcation where you don't have to do a lot of lesion modification. Look, I think those are the kind of cases where DCBs make sense. So here we did lesion prep first with a 2.0 balloon and then a 2.5 NC balloon. After the lesion prep, we thought we had a very good result. Remember again, those criteria, right? Angiographic stenosis less than 30 and the absence of a flow limiting dissection, obviously TIMI3 flow. Those are the three criteria I always think about. We liked those criteria, so we went with our DCB. We used the 2.5 by 25 DCB in this case. So again, one of the other things I try and teach my fellows, the DCB diameter shouldn't be larger than your last balloon diameter. So always balloon and do your lesion prep with the same diameter balloon as the DCB you're going to use. The DCB is just the last thing you're putting on. It's the coating on the artery. It's not there for lesion prep or lesion dilatation. And if you do that, you're going to get better outcomes. So we did the DCB, and this is the kind of final results you're going to see if you do good lesion preparation. This is kind of where you want to start. Once you start doing these, you can start taking on more complex cases, like the one I'm about to show you. So here you see again, no flow limiting dissection, minimal residual stenosis, and TIMI flow 3. So here's my next patient. And again, in the past, I heard people saying, yeah, but DCBs are for young patients. I actually don't think there's an age limit for DCBs because a lot of my elderly patients that I'm doing structural procedures on are actually pretty high bleeding risk patients, and they're patients in whom I like to avoid long durations of DAPT. So I've been considering them more and more for DCBs. So here's a patient, high bleeding risk because of his age. He's had bleeding in the past. His creatinine's 1.9. His GFR was sitting in the 20s. He came in his first presentation with decompensated heart failure. He had an ejection fraction, actually probably a little lower than written there, probably 20 to 25%, with severe aortic stenosis and triple vessel coronary disease. So he always coronaries, an occlusion of his RCA. His circ has severe disease with sort of very severe calcific stenosis in the proximal RCA, and the LAD has a CTO of the LAD with left-to-left collaterals. It's a case where maybe some people would say, well, are you crazy even considering DCBs? Well, maybe I am, but my patient's a high bleeding risk patient. So let's see what we did. We did a 26 millimeter valve first. We got rid of the aortic stenosis. We tend to, in my center, prefer getting rid of the AS first, so then we can deal with the coronaries. We then went ahead a week or two later, we brought him back we started with the circumflex, thinking it was going to be the easier case or the easier lesion. There was also the CTO, the mid-LAD. And our plan was hopefully maybe some IVL on the circumflex and do a DCB to try and avoid complex bifurcation stenting and multiple stents in an elderly patient. We couldn't pass balloons, so we had to do a rotor. And you can see we're doing this with balloon pump just because this guy's EF was 20% after the TAVR still. He actually, that was a pretty complex TAVR. He arrested I think 6 or 8 times during the TAVR just because of his low ejection fraction and the coronary disease. So after good lesion preparation, got good flow into the distal circ, struggling to cross into this large marginal, eventually had to star that to be able to get flow. And so did a dissection. Once we dissected that, then treated it with multiple agent balloons in the marginal all the way back to the circ and then into the distal circ. Did imaging, and this was the final result, which again was okay. I think not bad. Maybe you see some double lumens in the marginal from the dissection, double lumen in the circ as well from the dissection. But again, we did this procedure with, I think, 20 cc's of contrast because his GFR was 25. So we didn't want to do too much contrast in this patient. We decided to stop here after this result and wait to see how this would heal with the DCBs and wait maybe a couple of months before doing the LAD. So he actually came back this week. This is what his vessel looked like before. This is afterwards. There's actually pretty good remodeling of the proximal circ and marginal. I mean, maybe this distal vessel here doesn't look as great, but the rest of it looks actually pretty impressive, considering how bad it looks. And at this stage, we then did the LAD, which was occluded, opened that, and used again a couple of drug-coating balloons to be able to avoid long stents in this patient who can't tolerate long-term DAPT. So here's his final result, which we thought was pretty acceptable. His EF is now improved to 35% after these two procedures. We'll see him in a month's time. He's going to do a month of DAPT, and then we're probably going to stop his Plavix because of his high bleeding risk. But I think we wanted to highlight that, or I wanted to highlight that as you get comfortable with this, you can treat even more and more complex cases. This patient's maybe a little bit, I tried to choose two cases that show the two extremes, really, of what you can treat as far as DCBs. But I think you can get great results in both. Start with easy cases, please. And as you get more comfortable, you can use these balloons in more complex cases. I think, besides the typical lesion subsets we talk about, which is diffuse disease, long lesions, bifurcations, and now with Bernardo showing you some CTO data as well. I think another great indication is high bleeding risk. We don't talk enough about that. There's a lot of interesting data from Europe happening on high bleeding risk patients. But I do think in multivessel disease, having this as part of your armamentarium will allow you to minimize your total metal burden. Thanks to the four of you for great discussion, great presentations. I think DCBs are really urging a new era. And I think, we can all learn and adapt our practice. Enjoy the rest of your evening. Thanks for the faculty for making TIO successful, and for all of those of you for joining.